Hello, everyone. This is Greg Randolph from Harvard Medical School, Department of Laryngology in Boston, Massachusetts, in the USA. Thank you so much for the invitation to speak today on recurrent laryngeal nerve and superior laryngeal nerve management during thyroid cancer surgery. I'm honored to speak at the International Head and Neck Oncology Conference at Sri Shankara Cancer Center. I want to also thank the organizers of the meeting listed here, Dr. Rao, Dr. Srinath, Dr. Sriram, and Dr. Sasimuli. I appreciate their time in putting together this wonderful program, and again, I'm honored to be a speaker here at focusing on the recurrent laryngeal nerve primarily. This is the Charles River, which is the river that runs through Boston here. And these are my financial disclosures. These are institutional research funding grants from those units listed. I'll be presenting some research during this talk, and I want to thank all of my colleagues here at Harvard, medical, endocrine, hem-onc, endocrine surgery, our fellows and residents, and especially the group in the middle, my research group, which have worked on some of these projects, and all of these people are responsible for some of this work. I'm going to divide the talk into three portions. One, recurrent laryngeal nerve anatomic studies, which I think is the basis of nerve management, discussing some intraoperative neural monitoring aspects of some of that RLN research, then look at some data and guidelines relating to RLN invasion, and then end with what I call the Lazarus effect, which was just recently reported in the journal Thyroid as a result of neoadjuvant therapy for advanced thyroid cancer. So these are the three areas that I'll be speaking on. The first on RLN anatomic studies. It is really our understanding of the anatomy of the recurrent laryngeal nerve that allows us to manage it optimally. This is a publication of 1,000 nerves studied anatomically and electrophysiologically in 17 different centers across the world, published in the journal Thyroid. Why are we so focused on the nerve? The nerve we feel is injured in even experienced hands in up to 5 to 10% of cases. There are medical legal issues related to that. We also know that unilateral cord paralysis has a significant impact on quality of life. And we also know it's not so easy to sort it out sometimes, because you can have up to a third of patients with vocal cord paralysis postoperatively that do not complain of voice symptoms. We also know that nerve injury is, in many settings, underreported. This is some of the work on the British Association of Endocrine and Thyroid Surgeons, their audit, and it shows that the higher rate at which you perform laryngoscopy in patients, the higher the rate of vocal cord paralysis is. So if you perform it postoperative laryngoscopy in less than 30% of patients that you operate on, the rate of paralysis is about 2%, whereas it doubles basically to 4.2% in the setting of nerve laryngoscopies that are performed closer to 80% of patients. So the more you look, the more you find, and nerve injury is really not so uncommon as we have hoped. Again, this is probably underreporting nerve injury in community settings, because the British Association is a group, as the Scandinavian Quality Register similarly has reported, a group of surgeons that are focused primarily on thyroid and parathyroid surgery, who are voluntarily giving their data. So one would expect that in community settings, in many settings, the rates may be significantly higher in people who don't specialize in thyroid and parathyroid surgery. So again, back to this paper, we looked at 17 centers, 1,000 nerves at risk. We looked at how those nerves reported by those surgeons of the International Neuromonitoring Study Group panned out in terms of this empiric system of international RLN anatomic classification system L1 and R1 are the normal, textbook normal pathways, trajectories of the nerve in the neck. And to the right, the different columns are different acquired or embryologic alterations of the nerve that might be present. And then, so we looked at how these 1,000 nerves panned out according to those normative and acquired abnormal pathways. And we looked at a number of other surgical important pieces of information relative to nerve anatomy. Was the nerve fixed or splayed to the undersurface of the thyroid gland? Was it invaded? Was there a posterior leaflet of the ligament to bury? Was it branched? Was it less than 1 millimeter? We looked at also neural monitoring information, loss of signal, and the degree to which the nerve was dissected. And so we found basically a complicated chart, but I want to focus just on this one column. The trajectory of the nerve in the neck, we estimated empirically prior to the procedure, prior to the study, that the normative trajectories would be present in 90 to 95% of cases. It turns out when you actually look at the data where the nerve was in the neck, both left and right side, about 23% of nerves at risk followed an abnormal course. And this was increased to a third of nerves when loss of signal occurred. We also, so the nerve is not where we think it should be according to the textbook about a quarter of the time. So we think this is probably one of the reasons why the nerve is injured, is that the textbook is not always correct. It is incorrect in about a quarter of cases. We also found that the nerve moves when the thyroid is retracted. That is, the nerve at risk is fixed, splayed, or entrapped by thyroid disease in some way, banding fascia, bridging vessels, in about a 30% rate. So this was another reason why we thought that as we move the thyroid, so the nerve moves in about a third of cases. And so here is the data looking at that. About 1/4 of cases, the nerve was not following a normative trajectory. And so let's look at nerve monitoring in this study. We looked at V1 through V2 information right and left throughout the cases. All of these surgeons were members of the neural monitoring study group, and so they followed the strict adherence to the guidelines in obtaining neural monitoring information during the case, and so this was a treasure trove of information. And so I'll get back to that in just a second. We found that in terms of mechanisms of injury of the nerve, that traction injuries were present in about 2/3 of nerves that were injured. And of those traction injuries recorded electrophysiologically during the surgery, about 82% of them were resulting in vocal cord paralysis postoperatively. We did not see transection or constriction injury in this study. In terms of all of these factors, electrophysiologic and anatomic, what were the main on multivariate analysis, what were the main findings that were responsible for the few nerves that had either on the left loss of signal, a significant adverse electrophysiologic event during surgery, or actual vocal cord paralysis postoperatively? And you can see here that abnormal trajectory of the nerve fixation, and the increased severity of disease and more extensive dissection of the nerve were related to both of these adverse outcomes. Again, the adverse outcome of electrophysiologic adverse EMG events occurring during surgery, and the ultimate postoperative vocal cord paralysis as the two adverse events that we looked at. In terms of nerve monitoring, this is a very, very good test. The negative predictive value, that is the preservation of a positive signal from the beginning of the surgery to the end of surgery, related to normal vocal cord function, 99.8%. So not a perfect test, but nearly a perfect test of normative function in the recovery room if you preserve that signal. So very valuable information. So 1 out of 4 nerves what's the conclusions, the summary? 1 out of 4 nerves follow an abnormal neural trajectory. About a third of nerves are fixed to the capsule of the thyroid, so beware as you retract the thyroid, so you may be retracting the nerve in those circumstances. About 40% of the nerves were entrapped at the ligament very specifically, and that abnormal RLN trajectory, nerve fixation, and more extensive nerve dissection are strong predictors of both loss of signal electrophysiologically during surgery and vocal quadrasis postoperatively. Also, nerve monitoring is a very significantly accurate test with a negative predictive value of nearly 100%. We are now redoing this study with 10,000 nerves at risk, and we're just about there. Given the nerve monitoring importance and validity of that test, I wanted to then just talk a little bit about some nerve monitoring pearls in a couple of different topics, things that may help you in managing the nerve in more advanced thyroid cancer surgery. Some of this was presented at the recent World Congress of Thyroid Cancer in London, and I'll give you some information about our upcoming Congress in Boston at the end of the lecture. This information was also contained within a laryngoscope supplement in 2018, which is a very valuable nerve monitoring resource. This is the first of the 2 guidelines that were published in that neural monitoring supplement in 2018. And so let's look at some of the key applications of nerve monitoring. First, set up the document. This guidelines document discusses respiratory variation as an electrophysiologic test of a neural endotracheal tube, neural monitoring endotracheal tube placement, which is of course critical at the beginning of surgery. It also talks about correlating the electrical signal with the palpable signal of the digital examination of the posterior plate of the cricoid for the PCA contraction. And it looks at basically the normative data. Now, neural monitoring having been done for nearly 20 years or so, we have a very large cache of information of accurate left vagus, right vagus, pooled RLN and pooled EBSLN electrophysiologic data. So the waveforms, the amplitude, the latencies of each of these nerves is unique and is characteristic. And so that normative corridor of electrophysiologic information during surgery is very well understood, and this information is also contained in the guidelines. We know that when things go sideways, when the nerve is injured, we know that the amplitude decreases and latency increases. A smaller event and a event that is slower arriving at the larynx, basically in the setting of evolving neuropraxia. We also know that there are different stages of electrophysiologic decrement, from normal to preliminary adverse EMG changes to more evolved, definitive neuropraxic signals that can be obtained during surgery, and the guidelines also discusses this. And ultimately, loss of signal when you have a nerve that is not stimulable anymore. This is the final ingrained, evolved electrophysiologic neuropraxic change, and this is when a waveform no greater than 100 microvolts can be obtained with stimulation of the nerve. And so the guidelines is really a worthwhile document. It discusses, the white and black values of nerve monitoring. The initial prior to dissection, black is the final at the end of dissection, and then during surgery, you can either have green normative, yellow beginning to become adverse, red more ingrained, involved adverse alterations in neural signaling, and all of the details are contained within this guidelines. I would strongly recommend it. It really gives you a sense of the thyroid surgery as a flow of electrophysiologic information that the surgeon is then empowered by knowing the exact functioning of the nerve at any point in time. If the guidelines also discusses the role of troubleshooting. It's a fairly complicated system, neural monitoring, and so you can use the laryngeal twitch, its presence or absence, as the beginning step in sorting out, is this potential alteration in EMG activity actually neural loss of signal or equipment-related problems? And so the assessment of laryngeal twitch is discussed as the key crossroads in troubleshooting a nerve monitoring system that is not working, that is showing you potential loss of signal. Nerve monitoring is also an excellent tool for SLN monitoring, superior laryngeal nerve monitoring. The SLN is, of course, very important in higher pitches and in projection of the voice, more difficult managed with large goiters, where the goiter excavates the area of the perilaryngeal region, the nerve, as you know, flowing down from the vagus from on the side of the inferior constrictor. You're all aware of the Cerné classification, and 2A and 2B types are very intimately associated and therefore at risk in superior fold management. We've looked at nerve monitoring as it relates to the EBSLN, and we found several interesting things. We found that the laryngeal head of the sternothyroid muscle is a wonderful and reliable predictor of where it inserts on the oblique line of the larynx for the pathway of the EBSLN on the inferior constrictor as it descends to the cricothyroid muscle. This is a reliable position. In about 70% of cases, the nerve may be subfascial, that is kind of not able to be seen at external first view of the side of the inferior constrictor. You can nonetheless, with the nerve stimulated, dissect it through those muscle fibers, and even when it is subfascial, you can stimulate it up under the laryngeal head of the sternothyroid muscle and reliably get a small waveform on the monitor and a reliable cricothyroid twitch. There is the reason why you can stimulate the EBSLN, which goes to the cricothyroid muscle, and get a glottic waveform identified on the endotracheal tube, is because of the human communicating nerve, which is present in humans and canines, that connects the distal portion of the EBSLN as it penetrates the two heads of the cricothyroid muscle and innervates the anterior third of the vocal cord, again, both in canine and humans. And so the waveform is small, though, and it has a early short latency, and so it can be difficult sometimes to find. It is generally about a third the waveform that is resultant on the endotracheal tube by stimulating the EBSLN is typically about a third of the ipsilateral RLN amplitude. There is a guideline by the Neuromonitoring Study Group written by Marcin Brzezinski, an excellent guideline looking at all of these information that I've discussed, neuromonitoring as it applies to the EBSLN. This is an excellent article. It discusses the laryngeal head of the sternothyroid muscle, and I would recommend it. Let's move on to then the second topic, which is the RLN invasion, looking at both data first and then guidelines relating to the management of the invaded recurrent laryngeal nerve, obviously important for all of us as we manage the nerve in settings of especially advanced or difficult thyroid cancers. We've looked at our data, looking at a subset of 65 patients with 66 nerves at risk with neural invasion, and then looked at some of the data I want to share with you in the management of these invaded nerves. These were 65 patients, 66 nerves at risk, mainly female. The age and follow-up is listed there. And we looked at and defined two types of invasion. Invasion A is where the nerve is attached to the tumor, but it is not fully infiltrated. There is an interface there, and it is adherent. The nerve is invaded, but not engulfed or encased, whereas in type B invasion, there is a engulfment, encasement of the nerve. That is, there's tumor within the substance of the nerve. And we looked at those two definitions of nerve invasion and then looked at some of the data. This is the surgery here. This is the nodal management. And the valuable piece in looking at these nerves is that we manage these nerves, this fairly large number of invaded nerves, in different patterns, whereas 2/3 of them were managed with nerve resection, but 1/4 of them were managed with nerve preservation. And so let's look at that. We also, just to emphasize just what I had mentioned before about the British Association of Endocrine and Thyroid Surgeons, is that the importance of laryngoscopy in these patients, that we had 39% of patients who had invaded nerves had preoperative vocal complaints. So that means, almost 2/3 of these patients who in fact had nerve invasion had no voice complaints preoperatively. And when we did preoperative laryngoscopy, as we did in all these patients, vocal cord process was present only in about 40%. So again, in this subset of patients, which all have neural invasion, which relates to added difficulty in managing them at surgery, type A or type B, that only 40% of them had vocal cord process. All of them had nerve invasion, only 40% of them. So the vocal cord process pre-op is certainly a worrisome finding, but its absence in the setting of a patient who, for example, radiographically you suspect having nerve invasion, you should still have a high level of concern for nerve invasion. Again, only 40% of these group of patients with nerve invasion had vocal cord process preoperatively. And when we looked at multivariate analysis, looking at what are these different factors, including, importantly, resecting the nerve or not, relative to 5-year recurrence-free survival or 5-year overall survival, nerve resection was not statistically significant. It turns out that of all of the factors we look at, only the administration of RAI was significantly related to recurrence-free survival or overall survival. So again, nerves that are invaded, you resect them, that doesn't necessarily impact based on our data, on recurrence or overall survival. And so there's an implication of that. This is a large group of invaded nerves. Nerve resection did not offer statistical benefit. We also looked at complete tumor resection at the level of the nerve, and this was also not associated with recurrence or overall survival, only RAI was. And so we, based on this data, are concerned that the current TNM staging, which places the RLN with the larynx, esophagus, and tracheal invasion scenarios as a T4A, should be downgraded. The nerve should be taken out of the category of invasive viscera that the larynx, esophagus, and trachea are in, and be downgraded to be placed with strap invasion as a T3B tumor, we feel. In terms of guidelines, there's neural monitoring guideline, actually the second guideline in that 2018 supplement talks about all of these factors. It looks at how you can optimally manage the nerve, and this is with gross surgical information, preoperative laryngeal function, and intraoperative electrophysiologic data. All of those data fields impact on how you most optimally can manage the nerve. And so pre-op laryngeal function, the degree of invasion and tumor parameters at the time of surgery, intraoperative proximal EMG, activity of the nerve, and also an understanding of other non-surgical multidisciplinary options that are available, as well as the patient's wishes, are all important in the surgeon optimally managing the nerve. The guidelines is a really helpful document. It talks about, well, how can you more optimally identify these patients through history, physical exam, and tumor characteristics. It again gets into detail about the different types of invasion, more minimal, though still attached, type A, and more infiltrative, type B. And then it looks at a number of factors that the surgeon may consider as he or she is managing a given nerve that is invaded. Some factors such as youth, papillary carcinoma, expected RAI avid tumors. On one hand, these would favor nerve preservation, but say an elderly male with a medullary carcinoma where RAI is not a tool and there are limited postoperative adjuvant therapies available, then your pendulum swings a little bit more towards nerve resection. Again, just considerations for the surgeon to think through what might be best for their given patient based on the patient host characteristics. It also looks at how you can optimally factors that would be reasonably considered as you manage an invaded nerve with normal vocal cord function. Remember, I told you that about 40% of invaded nerves have vocal cord paralysis. That means 60% of invaded nerves don't. And so if you have an invaded nerve with normal cord function, the guidelines show some algorithms that might be helpful, and also show in that 40% an invaded nerve with an ipsilateral cord that's out, how you can manage that patient optimally. And then probably the most difficult scenario that we all face, that with a invaded nerve on an only functioning nerve, say the contralateral nerve is out because of past tumor activity or past surgical complication, and now you have recurrence, for example, on the ipsilateral nerve, which is the only functioning nerve. So some considerations, there's no perfect pathway here, but some considerations to optimally manage such a nerve. And then I want to finish the talk today with the Lazarus effect, which I think is very interesting and helpful for us to understand. This is a look at the return of vocal cord function and the subsequent surgical preservation of the nerve in patients with advanced thyroid cancer who are undergoing neoadjuvant therapy. That is, prior to surgery, they are undergoing neoadjuvant therapy, chemotherapy, prior to the thyroid cancer surgery. And so this is a multi-center retrospective review, 7 patients with a presentation with advanced thyroid cancer with vocal cord paralysis. And these 7 patients all had return of vocal cord paralysis function, return of function of a paralyzed cord with the neoadjuvant therapy. The average return to time of vocal cord mobility, presenting initially with paralysis and then the cord waking up in the setting of neoadjuvant therapy, is about 3 months. 7 patients this was true for. And when these 7 patients then went to surgery, all but one, or the nerve was able to be preserved. So really quite remarkable. You know, this impacts on how we think about nerve invasion. Many years ago, we would think that nerve invasion with a carcinomatous solid tumor would be, with vocal cord paralysis, was a permanent event. But the time scale of nerve invasion perhaps varies. The ability of this nerve to recover may be different with different time scales of invasion. It may be different with different histologies, with different molecular definitions of the tumor. It may be different with different neoadjuvant therapies. And not all nerves may recover, but it's a very interesting outcome, a parameter to look at in patients presenting with nerve paralysis. And as you all know, that the resumption of vocal cord function on one side of the larynx really expands a patient's surgical options very dramatically. And so this is very interesting, we think. So I want to, again, thank you so much. I think this is a wonderful conference that you're having at Sri Shankara. I wish you all the best. I know you will have many different excellent lectures. I've reviewed the program. I'm sorry that I can't be with you in person, but my schedule prohibits this. But I'm honored to share my information with you. We've spoken about nerve anatomy and electrophysiologic studies. We've talked about nerve invasion, both some data from our unit and some guidelines from the neuromonitoring study group. And we talked about this new and I think remarkable Lazarus effect in advanced cancers treated with neoadjuvant therapy. So I want to thank again all of the organizers, Dr. Srinath, Dr. Rao, Dr. Sri Ram, and Dr. Sasmuli, very much for the kind invitation. I do want to invite you in turn to several programs. We are very focused here at Harvard Department of Otolaryngology on education, and we do have a quite good course, I think, surgery of the thyroid and parathyroid glands. This next iteration of this course in 2026, November 20th and 21st, will be our 30th anniversary of this course, so I would welcome you. It's going to be especially good, I think. This will be in Boston in person. And then also we have, I mentioned the London World Congress. We will be having the next World Congress 2025 in Boston, July 9th through the 12th. And this is, we're excited about this. This is the largest thyroid cancer meeting in the world, and it has an outstanding program. The registration is open. You can look at that QR code and go to the website. It's an outstanding program with pre-Congress activity, RFA course, ultrasound course, 3 full days of Congress, tumor boards, plenary sessions, instructional courses, really free paper sessions. You can submit abstract, you can submit videos, and we would welcome you and your work at the World Congress in Boston. Again, thank you so much, and please enjoy the Congress. It's my honor to participate. Thank you so much.